Hey friends, it's Mike Mutzel here. Thanks for tuning back in. Today we're going to demonstrate PRP, which is platelet rich plasma on my elbow and actually my hair. We're here with Dr. Tyna Moore and Hannah, and we're going to draw blood and go through the steps on it. So, want to dive into it?
Yeah.
Cool.
Yeah.
All right guys, so here we go.
And I think a large part of PRP being successful is not just the application of the PRP into the areas, but the cell signaling that occurs from the patient's body in response. And so having, a low sugar, low carbohydrate, high healthy fat, kind of like you eat and I eat, diet, with plenty of protein. So I'll often hop patients up on collagen, vitamin C and zinc, which are known to be collagen boosters. Great, quick touch. Nice. Okay, gently release your hand.
That was it?
That was it.
That was so easy.
I'm good at this.
Oh my gosh.
I had an autoimmune I still have it, blood disorder when I was young, when I began my work for the naturopath that I used to work for, Dr. Rick Marinelli, and he was so good with blood draws, and I had to get my blood drawn all the time because of that stupid condition. Yeah. And so I swore up and down, if I ever had to do this professionally, that I was going to be damn good. So there's sometimes there are a few stem cells present in PRP. Mostly it's growth factors, but whatever's in my syringe, I'm still doing prolotherapy technique, and I think that's really important. I think a lot of people go to orthopedic doctors who don't know prolotherapy technique, and they just get some, and I see these patients in my office later when it didn't work. They get some juice put in the joint, and they say, well, it didn't work. And it was like, well, your whole rotator cuff is involved, and you have to treat all of the structures, including the intra-articular inside the joint. And that's the big difference. And so it doesn't matter what's in my syringe.
So that trauma, inducing the trauma is part of the healing process. Yeah. Because the tissue's avascular or not, it's not getting a good blood supply,
Not a good blood supply. So almost everyone sprained an ankle. And when you sprain an ankle, you realize it's a long trip back, right? It's hard to come back from. It's because those ligaments and tendons don't have a good blood supply. They're notoriously low in vascularity, and so, or they'll start to heal and they get kind of this like angiogenesis, mucky blood supply that comes. And so what we're trying to do is reignite a modulated inflammatory cascade. And what's the other thing everyone does when they get hurt?
They don't move much.
And they ice it.
And
they use non-steroidal anti-inflammatories, right? NSAIDs. And that completely shuts off the healing cascade for the first 10 to 14 days. Without that, each portion of the healing cascade can't go to fruition. And that healing cascade in total, from the time you get injured to the time you actually have healthy collagen deposition that's strong and stable, is about a year. Wow. So amazing. If you cut it off in the first few days with ice and NSAIDs, you're basically bailing on the entire process. Wow. You are robbing yourself of good, healthy healing and collagen deposition at the end of the year. Wow, really interesting. So to go back, what you were saying is some people may roll their ankle or hurt their tendon or whatever, they take NSAIDs and they come to see you years later because that healing process never occurred properly. It abated, yeah. Wow, that's really interesting. And so we're creating an modulated inflammatory immune response. And then again, it doesn't really matter what's in my syringe, same technique, prolotherapy technique. I'm an old school prolotherapy girl. And then we, if we need, for like your condition, lateral epicondylitis, that's kind of persnickety. So PRP is preferred, in my opinion, after treating it many, many thousands of times. That was easy. That was honestly, no kidding, the best, easiest blood draw. I didn't feel it go in, there's no pain. Good. All right, so step 2, we're gonna go down into the lab and spin down the plasma, Yeah. Hey guys, Mike Mutzel here. Thanks for tuning back in. We are going to demonstrate PRP on my elbow. So I've had some bicep and elbow pain. I injured it about 2.5 years ago now, and I've gotten one treatment on each of the elbows. So we're going to look at the extent of the damage on the ultrasound. We already drew my blood, and then we're going to actually inject the tendons and ligaments and so forth to induce some micro trauma to help to rebuild the tissues here so that I don't have lingering bicep pain. So interesting. Yeah. Is this pronated or supinated? That's supinated, so you're holding a bowl of soup. So supinated, when I do arm curls like that, Tyna, that's when it hurts. So like I can do hammer curls, I can do pull-ups, but if I do pull-ups this way, I get bicep pain here, and then when I do pronated on this elbow, that's where that hurts. So hold this with that hand, other hand. There you go, and then let me see something. Okay. You can rest it down. There should be a little. So that's tender right there. Yeah, so your biceps tendon starts here, wraps around the radius, comes up your arm here, and then inserts on your shoulder. Do you have shoulder issues?
I've torn this rotator cuff
That's
a few
right.
times, separated class 3 separation. Yeah.
So we'll treat it down here.
Okay.
Where it inserts on the radius, and we'll treat the rest of your elbow, and then we might want to visit your shoulder someday if you want.
Okay.
That's a kind of a different beast.
Yeah, that seems...
Getting your shoulder done is
not so fun.
Is that tender?
That is, yeah, that's the most... You hit
so that's the biceps insertion.
Yeah.
And then we can just look on here just to look at the... Most people, when they have lateral epicondylitis, they call it, or lateral elbow issues, it's the ligament that surrounds that bone that's underneath the arrow.
Okay.
That's the radial head. And that bone rotates like this. The other bone is a hinge type joint. This one is a rotational. You can see it. Look, if you look at it on there, you can see it rotating under.
Yeah.
Anyway, that's often the ligaments surrounding that bone, and then this whole joint space is usually what's banged up on people. And then where this wad of muscles inserts up onto your humerus is right up in that little gully that you see under my...
Kind of right there, hey?
Yeah.
Yeah.
That's a big spot.
That looks a little gobbledygooky, like you were saying. So for I don't know that we were talking beforehand. So we want linear patterns, not this jarbled stuff, hey?
And when you see, it's really easy for me to just re-angle my probe and create the illusion of a problem. So we have to be careful. And often what I'll do is compare someone who's normal side to their abnormal side, if they have a normal side, and just kind of see what's different. You know,
right.
I'm not a super great diagnostician with ultrasound. I use it more for needle guidance when and where I need it. But it does tell me, you know, if you had no elbow problems there, and we were to look at that elbow and then compare to sides, I'll see. I had a guy come in with a biceps tendon that was very tender, and under ultrasound it was hugely swollen and edematous. But that's all we could see. We go to the other one that's normal and painless, and that looked nice and healthy and normal. And he was like, "Oh my gosh!" Like it was very compelling to him to see
that
the differences. So yeah, a little bit of gobbledygook there, kind of fraying, and see there's some black speckling in there.
Right. So I'm not just making it up in my head, hey?
No. It's just, you know, your tissue becomes a bit pathologic. So we are inducing microtrauma with the needle, but then we're shooting in a concentrated blast of growth factors with the PRP, it's like dumping in a bomb of great immune goodness.
Yeah,
It'll heal you up. Yeah. Cool.
Awesome. All right. Well, that really helps. So we'll go back in there.
So that's actually really pretty blood. So the platelets and what we want is suspended right here, and then the red blood cells. So in men, I generally see more red blood cells than I do in women. A lot of that, I think, is to do with your guys' testosterone. Sometimes I wonder if it's chronic dehydration, but I do see it more in men. I rarely see this in women. So this should be more of a 50-50 ratio, and preferably more plasma than actually red blood cells. But I think that a lot of that, honestly, when I see men on testosterone replacement, or they're just lifting a lot and they're super healthy and young.
You see a little bit more red blood cells to plasma, hey? Yeah.
For sure. And we can tell a lot. Hannah is who makes up the PRP at this point, and we can like pretty much tell how somebody is just based on what their blood looks like. If their platelets are sticking together, if this is too mucky, gives us a lot of information. So we don't mean to be judgmental, but we'll come back in and be like, so your blood kind of, like you might want to work on X, Y, and Z. Now this spun out in a different centrifuge, so you're seeing more plasma G-force.
Yeah.
You see the platelets kind of clouding that layer there?
So there's a little bit more red blood cells than you normally see. Hey?
Yeah, but you're a young man with good testosterone, so I wouldn't think anything of it.
Could be slightly dehydrated. I did sauna quite a bit last night, but per your recommendation, I drank a lot of water this morning. But
I think that people end up playing catch up sometimes.
Yeah.
And not realizing it, you know?
You mean on the hydration?
Yeah, you travel a lot, so I think that you're probably getting sucked dry just from the act of going up and down in the air and being in the air. I think that's fairly dehydrating to people.
You know what? It's funny. That kind of worried me about doing this now, because I was traveling for the last 2 weeks, and I was like going to bed at crazy times and not eating. And I was like, oh my gosh, are my stem cells going to be good, you know, for this treatment? But I eat really clean. But anyway, that's an important component, right?
Yeah, it's true. I mean, being hydrated is critical, because I make my PRP, so if someone's well hydrated, I can do more. I can get more regions. Often people will charge you by joint. I charge you generally, the cost is in making of the PRP, and then as much of that as I can use. I mean, I'll treat as many areas as I need to, for a negligible price increase. I try to make it really all-inclusive and really affordable for people, because like we talked about with your shoulder may be related to your elbow, and if you were if it really were a bigger issue, I would probably encourage you to get that treated today and, focus on the two things that are connected. It's kind of like knees and hips,
right,
or hips and low backs. I want to have enough PRP to treat both regions, because piecemealing it like that, I think, is not how you get people better fast. I think you have to kind of figure out, you have to be good at diagnosing, and you have to be good at musculoskeletal medicine, and then figuring out, what does the patient need? My hip pain that I'm having treated tomorrow, I know has everything to do with my sacroiliac joint. I know I have hip osteoarthritis, but I think that's negligible compared to what's actually happening in my back and my pelvis. And so treating both together, I think, that's the only way I'm going to get resolution.
Getting at the root cause, hey?
Kind of got to chase it around. You got to know your stuff. I train a lot of doctors on prolotherapy and PRP, and anybody can learn to do these techniques. Learning to do them well is a whole different issue, but I think that learning to diagnose and learning to treat the pain generators and find the pain generators is key. That's the magic.
Right. We did the 2 spins, and that's what we're doing right now.
Right.
So we're kind of talking offline. I think it's good to bring up this idea of having overall health before someone gets into these regenerative therapies, and kind of let's talk about that.
Sure. So I had this idea for years as I was treating thousands of patients that if you're not healthy, you're not going to get a good, robust response. So, if your hormones are off, or your gut's off, or your sleep is off, or your diet's off, whatever the situation is, or you're morbidly obese, or you're sucking down Mountain Dew every day, your platelets are not going to be your platelets or my platelets.
Sure.
And our platelets are very different. We're different genders, we're different age groups. And so what does that mean, and does that matter? And I think in the PRP land, they're really trying to standardize things. They're trying to just standardize processing of it, how we make it, how we inject it, et cetera. But the thing that I'm always waving my hand about is, what about the patient? What about the patient population? Because we're comparing apples to oranges. And so for me, that was really compelling, and I started sending more and more unhealthy patients out of my office. I would still accept them in, and then I would send them off. And I was feeling guilty about that. I was like, there's got to be a way to pre-screen people, so that, not that I am trying to reject anybody, but I don't think that paying cash services for something that isn't necessarily going to work is an ethical thing to do. And so I caught some heat from my colleagues about it, which is okay. But then I started diving into the research, and it turns out, if you're morbidly obese, your stem cells are not in good shape. So if we were to do a stem cell procedure on that patient, suck their fat out, not only are people who are obese and have diabetes and blood sugar issues at a much higher risk for getting an infection from a procedure, they're not going to heal well, and their stem cells are
crazy.
Yeah, and so I started looking at growth factors, and it turns out if you're chronically inflamed, your growth factors are no good. If your cells are dying, they start to signal the cells around them to die. Wow. They set off a whole cascade. So it's like, to me, it just doesn't seem like the best thing to do. So I would rather get somebody optimized, get them healthy, and that can take a while. So there's things we can do to cut their pain down, to get them moving, but I think people need to really start focusing on, and I have programs online about it, and I know we all do, but getting your nutrition dialed in, getting your movement dialed in, getting all of those things handled, then receive the treatment, and then get more bang for your buck. And so I call it tissue optimization, but
that's awesome. I love that.
It's just like, let's optimize you, let's get you in good hands. I don't do that work here anymore necessarily. I send them out to a good naturopath in town, and I get them dialed in, and when the docs I work with know when they're back in healing mode, send them back for
the joints.
Yeah,
right.
And so I might see them a year later, or I might see them 6 months later, or I might see them 2 years later, and they're like, I did the work, I'm back. And do they always get results? Hard to say, but
it's better than when they started. They're going to get more mileage out of the treatment.
I think so, because if I'm taking your PRP right now, so I was at a conference, interestingly, and I got PRP, and I had been eating gluten and drinking whiskey and staying up too late at the conference, having too much fun. When I received PRP that day, it was the most painful PRP I'd ever gotten, because my blood was super inflamed. I probably had mass inflammatory markers going on, and
really interesting.
It was hell, and I hurt for 5 or 6 weeks after, when normally it's like a couple days and I'm fine. And so that was the good lesson. That's when I really started thinking,
there's more to the story here.
Way more. And then my mother, who, bless her, she's really pulled her act together, but she was that obese, 60-some-year-old, metabolic syndrome, high insulin kind of picture. And I was doing PRP on her, and it was no longer working. And she kept saying, she wasn't blaming me, but she's like, why is this not working? This used to be such a godsend for me. And I'm like, Mom, you're terribly deconditioned and you're not eating well. And she listened and she took it to heart and she did it. And I'm so proud of her, you know? And so now she's like, I will get treated when I am
healthy.
Let me clean my diet up for a few weeks. If she's sort of fallen off, she's like, and so for me to receive PRP, I really dial in my diet. I dial everything and I get, I pull in the reins, keep the alcohol and sugar low, and then go receive treatment. And it's a much nicer process for me. It's way less painful, and then I get better results. So
really interesting. Now, to bring it in like that, like clean up your life before treatment, like are we talking 2 weeks, 10 days, a month, like what?
It can be months. I mean, that's what I was saying. It can be 90 days. It can be a year.
But for healthy people like you and I?
Oh, I think a good 2 week.
Okay.
So I had this basal cell carcinoma removed from my chest, and I knew it was coming. I knew I was going to be applying PRP topically every day, which did you see the picture?
I did, yeah.
It's amazing.
Right.
It healed really well. And so I'm in like clean mode right now.
Yeah.
My alcohol has been nil, my sugar has been nil, tons of leafy greens, tons of microbiome optimization, all the stuff that I learned from you. Just healthy fats, healthy protein, and I'm ready. So I'm going to get PRP tomorrow, and hopefully it'll be.
That's awesome.
So I think if you're leading a decently clean lifestyle, it's a pretty quick
transition.
Yeah,
it may not be that 6 months, 18 months like you mentioned for the overweight person that never exercises.
And then something else we talked about, and I don't know what part of it got caught, but just that arthritis really is an inflammatory metabolic condition of the joint, and the joints are their own organ system. Joe Tata talks about that, and it really blew me away the first time he said that. It's an organ system, and so we're treating them as biomechanical structures that we're just hacking into, but they're their own live structure. And I can tell simply by, when you get really good with needles, you can palpate with the needle tip. And my mentor always told me about that. It took me years to really get that skill. And now I can tell, just as I approach joint capsule, I know exactly what I'm dealing with.
Wow.
And I have a pretty good idea of the outcome at that point. So
if there's resistance within the needle, there's some inflammation going on.
Yeah, a normal healthy joint capsule should almost feel like thin, like a balloon, not even, just almost like a thin membrane. And an inflamed joint the patient will almost scream as you approach the structure because it's so inflamed. And then as you traverse the joint capsule, it's thickened and it's like a thick balloon.
Wow.
And it's gummy, and then the joint doesn't want to receive the fluid, and you get a lot of pushback on the syringe. And so I know the joint's actually contracting down. It's actually inflamed, and it's creating like an adhesive capsulitis type picture. So if I approach a joint capsule and the patient comes off the table, I'm like, oh, we're going to have a different clinical outcome here.
Right.
They'll still get benefit, but that's when I might stop. I might change a little bit of the solution in my syringe just to make it a little more anti-inflammatory. There's natural things we can do. Just kind of gauge where the patient's at. So, and I'm trying to create as much as I can online at different, just different size packages so people can at least have some kind of entry point. So for someone like you and I, it's like maybe we just need a couple week dial in. But that's something really hard to convey to patients. I hate to have them come in here and then have to wait forever. I'd rather them do the work on the front end, then get to me, or then get into the rejection therapy and get that done. The other thing that I think grabs me is a lot of doctors will treat patients they'll treat anyone that walks in the door. And I feel like that's pretty unethical because these patients will come in and say, well, what about diet? And the doctor will say, oh, that doesn't have anything to do with it.
Yeah.
Just like, And if you're going to do regenerative injections, that has everything to do with it. How you've been eating even the past, the microbiome adapts instantly to what you're putting in it. So I'm sure your immune system shifts in just as much. So the other thing I think that's important with our culture and obesity is that your cartilage cells, which everyone comes in here and says, I'm bone on bone, like it's some flag. I'm like, well, welcome to the club. Everyone who walks in here is bone on bone or they wouldn't be here. I'm the last stop.
Right.
People have done everything by the time they get to me and they're trying to avoid surgery. So cartilage cells, interestingly, if you load them too much, you kill them if you crush them. And if you don't load them at all, you kill them. They need some level of use. And so if you're looking at a very heavy morbidly obese person, they're sitting most of the day. Most humans in America are going from their bed to their couch to their desk job, back to their couch, back to their bed, right?
Yeah.
So they're not loading the cartilage cells, those little chondrocytes at all, so they're not getting any action. The only way to get nutrients in and out of a joint, to get the inflammatory markers out and to get nutrients in, is through movement. So we have a huge problem there. And then when they do decide to stand up on them, this is why I'm so against running for most people.
Yeah.
You have to earn your running. When they do stand up on them, they're crushing the chondrocytes.
Yeah.
So it's a mess. I mean, we're looking at hip and knee replacement rates coming up with the baby boomers, like it's going to bankrupt this country.
Wow, just that alone, hey, not
just
including.
hips and knees. Hips and knees alone right now are coming down the chute, and cortisone disintegrates your joint over time. That's not great because we're dealing with a structurally unsound joint anyway. Why would we want to create more laxity, right? Yeah. Surgery is not a great option in most cases, and they've just come out with a study saying that knee meniscal surgery is not any better than just resting and waiting.
Wow, I didn't know that.
Yeah, so we know that long-term cortisone use in the elbow completely disintegrates the structures and creates terrible instability later on. So the standard of care is a little bit broken. It's a lot broken in orthopedics, not my favorite thing. Yeah. And cutting things open and resewing them. Another popular surgery that I hear suggested to patients is microfracture, which is where they drill into the bone to try to induce bleeding. Well, that's exactly what we're doing. We're taking your blood and we're taking out the best of the best and we're putting it back in there. Why would you need to drill into, like that seems pretty severe to me.
Pretty invasive.
Really invasive. Right. And so the answers are either not the general care answers, and then there's PT, which I think is critical. However, when you look at a joint, when you have internal joint disruption, so if you have a labrum in your hip or a labrum in your shoulder or a meniscus in your knee that's torn, or one of the stabilizing ligaments within the joint that's torn, neurologically the muscles around the joint sort of shut off and start firing aberrantly. So you can rehab that joint all you want, and you may or may not get resolution, but generally speaking, you're getting aberrant firing patterns because neurologically things aren't working because you have internal joint disruption.
Interesting.
So getting something in there to heal it, whether it's Prolo or PRP or stem cells, to heal up what's inside the joint, treating all the extra-articular structures like we talked about, and then sending the patient to PT. Now the joint's going to work much more properly, and pain isn't going to be a factor. So.
Now, is that why the lidocaine or procaine is in there, to kind of reset that neurological signaling?
Somewhat, yeah.
Interesting.
For sure.
Dr. Naylor talked about that in the packet.
Yeah, I mean, traditionally naturopaths are big on procaine. I think, you know, a lot of us have had to go to lidocaine because of the compounding laws, but I think the results I'm still getting great. I think if you can shut I think of it, the whole structure sort of PO'd. And if you can shut it off temporarily while you induce some healing, when it comes back online, that nerve will tap a lot more regularly, or so we hope. I mean, that's the premise behind trigger point injections or anytime you use a local, so.
Yeah, awesome.
Yeah.
All right, let's go check the blood.
Okay. So these are really low red blood cell, but with a little bit, and then this one is a much higher red blood cell product. And I use these where I need a little bit more spot welding.
Little punch.
Yeah.
So this is going to hurt more long-term, potentially cause more damage, whereas this is just all the healing goods packed into one.
This won't cause damage if you put it outside a joint, which we're going to. If you put it inside a joint, it can be definitely like a bomb.
I see.
You don't want to put a bunch of red blood cells in a joint, but it'll be for like persnickety areas where there's a lot of ligamentous tendinous disruption. That's what we want. And then this is nicer.
But we're not quite done yet. We're going to do a few more little goodies in here, right?
Yeah, I put a little bit of stuff in there to make it not hurt so bad.
Okay. So it's amazing, out of like 16 vials, this is what we're left with.
Yeah, right?
Double spin, pipetting.
Yeah, concentrate it down.
Love it. All right, so we're just marking
so
where we're
this is a messy marking.
Yeah.
When I train people in Prolo, I do a very strategic marking out, but I know where I'm going.
That's really tender right there.
Yeah.
Should I be watching this?
You can.
This will be interesting.
You'll like it, yeah. You'll like it. Let me find where I'm going again. I had that really nice shot. There it is.
Ooh, that's tender.
I don't know.
I mean, it's all good.
Okay.
I can't watch. Just rock and roll. You're good.
Quick touch.
Oh, can't watch it.
You're good. I want to light my needle up. You okay?
Yeah, but you got into that
tender spot.
Yeah, which is good. I know it's necessary.
Okay. Is that less tender?
It's less tender now. Yeah, you know what? I think the lidocaine kicked in because I felt it right at first, and then I didn't feel it.
Okay.
It's good though. Pain is good in this context.
No, I'm gonna do your whole annular head too. You tender here?
Yes, ma'am.
Okay, you're good. Quick touch.
Yeah, you got it, which is good.
I'm sorry.
It's good pain. It's actually not that bad, guys. It's just that initial.
Yeah, once that lidocaine kicks in. Some say don't put lidocaine in with a PRP, but I think that's a terribly mean thing to do to people.
Yeah.
And I've been doing this a long time, and I get excellent results. So I use just a little bit of lidocaine, and
just enough to kind of numb it.
I think people really appreciate it.
Yeah.
Last one here.
Okay.
And then I am going to go. Is that tender?
Oh, yeah.
There we go.
You hit a trigger point or something, hey?
Okay. Whew. And then I'm going to get that little biceps.
This one's going to hurt, I have a feeling, but this is the one that I really need.
It's okay. You're going to be okay. We're going to pronate you a little bit, and I'm going to find it again.
Yeah. So you're right there.
Right there?
Right there.
Okay. It rolls itself under the muscle, so all you can feel is a few fibers, but I'll get it. Don't you worry.
I don't know if I like this idea.
You're okay. You're okay.
And so this is probably the origin of the bicep. Well, the shoulder could be the bicep.
So the biceps tendon comes in. It's the only muscle in the body that inserts intra-articularly. It actually inserts onto the labrum. So the labrum sits like this. It's a cartilaginous spacer between your humerus and your glenoid, and the biceps tendon comes in and inserts. So a slap lesion, have you heard of a slap lesion?
I haven't.
It's a common labral tear, and that's when the top of where the bicep starts to pull off and rips the labrum.
I see. Got it.
It doesn't feel good. That's what I have.
Interesting.
Okay. Look at pretty Hannah.
Yeah.
Quick touch, you're okay.
Yep. Oh, yeah, you got it. Oh, yeah. Oh, my gosh.
That's it.
Yeah.
Yep.
It's all good, though. It's actually not that bad. It's just like at first.
Yeah, well, I think the tissue screams when you touch it with a needle. It's just not happy.
Yeah.
Okay, all done.
That's it?
Yeah.
Oh, man. Whew, it looks like...
Okay, right elbow's done.
Yeah.
Okay, so for the scalp, what we're doing is similar. PRP is basically a concentrated form of growth factors. So we are trying to induce regeneration in the tissues there. And so a lot of times it's just a matter of that follicle not dying. And so you reported that you had improvement in just less shedding.
Yeah.
Which shows a more robust follicle, I'm guessing, is that things are holding better, and that's what we want. So even if we don't reverse a ton of, you didn't have any hair loss really to begin with.
Not really.
A little bit of thinning, but it definitely can help abate a situation, and I look for that in joints too. I'm looking for the abating of degeneration. We may not move leaps and bounds forward, often we do, but more importantly is, can we arrest that process from continuing that disease process or that pathology, or not that this is a pathology, but.
Right.
I would definitely agree with you though that a lot of hair loss is lifestyle.
Yeah, I think so. I mean, family members, like I said, have much greater hair loss than I do, and so I'm just trying to preserve what I have, so.
Hair loss is a beast. Okay, I'm gonna start.
Let's do it.
Okay. Quick touch. I'll go quick so we can be done with this. When my mentor was sick and dying, I lost a ton of hair.
Yeah, I've noticed it definitely around stressful events and travel, actually.
Quick touch.
Yep.
Wow, all the travel you're doing, I know is taking a toll on you, but you're making so much good content. People are...
That's what I keep coming back to, right?
People love your work.
Oh, thank you. Gosh, last time I remember this hurting way more. I'm not complaining that it feels good, but...
Well, we're not using that more inflammatory PRP.
That stung like a mother. That's what it was.
So that's what most people use. Most people use kits. That's one of the reasons I make my PRP, is because people use kits. And those kits are high in red blood cells.
Yeah.
Anyway, we can put PRP pretty much anywhere. I do it in the genitals. I treat a lot of women's, or was for a long time. My assistant does it now, in the vagina, because a lot of those tissues will atrophy. And for clitoral stimulation, and you can inject male genitals.
Yeah, the P shot and the O shot, hey? I wonder too about the hair, if there's a blood flow issue too. Like,
oh yeah.
Yeah.
So one of the growth factors I think that works most readily is this VEGF. It's Vascular Endothelial Growth Factor, and I think that in a lot of cases that's what we're getting a lot of bang for, is that VEGF is in here in high concentrations, and that helps us. There's a couple growth factors that really help harness blood flow and regeneration of capillaries and